Gentle disclaimer to all of our listeners. All medical information mentioned in this podcast is purely informational. It is not individualized medical advice. Please follow up with your physician or medical practitioner for individualized care specific to your needs.
Hello, everyone, and welcome to the Know and Do Better podcast. My name is Dr. Melanie Carminati, and we are in for a treat today. We will be talking about fertility treatments with Dr. Edward J. Nejat of Generation Next Fertility. Dr. Nejat, thank you so much for joining me today.
It's an absolute pleasure, Dr. Carminati. Thank you so much.
So for those who do not know Dr. Nejat, he is the practice director of Generation Next Fertility here in New York City. Dr. Nejat is an accomplished fertility specialist and reproductive endocrinologist who considers the doctor-patient relationship to be paramount. His particular areas of scientific interest include natural cycle IVS, mild stimulation IVS, unexplained infertility, diminished ovarian reserve, oocyte cryopreservation, and oocyte donor-recipient cycles. He has received numerous awards and has been published widely in the field of reproductive endocrinology and infertility with multiple scientific journals. Dr. Nejat, thank you again. I wanted to start the conversation with just going through the basics of fertility treatments. What are the different processes, and take us through the basics?
Sure. Normally, when a patient first comes to see us, we start by having a conversation. How long has she been trying to conceive? What are her goals in terms of number of children? I think that's a really important question that often isn't asked early enough in the conversation, because the assumption often is, okay, let's just have one child and then worry about the rest later. Depending on the circumstances and depending on the long-term family planning goals, if someone wants more than one child and they're coming to see us, say, in their late 30s or 40s, getting to baby number one may be doable without difficulty. But then if they come back for baby number two in the mid-40s, that can be much more difficult. So sometimes we will have a conversation about creating all the embryos that will ever be needed for the entire family planning process up front before even the first pregnancy. And other questions we'll go through is if a patient has had any fertility treatments in the past, what were they? Have they been timing intercourse or not? Any medical problems, surgical history, all those sorts of questions we'll go through. And it's an opportunity not only to ask questions, but also to establish a rapport and a relationship with the patient. There's a lot of listening that I'm doing at that initial conversation that I think is absolutely critical to forging a positive relationship, because patients usually are coming to see us in a very vulnerable time. And even just picking up the phone to make an appointment, I think takes, for most women, a significant amount of courage. And walking through the door to actually, sit across the desk from a fertility specialist, I know can be really intimidating and challenging. So we try everything we can to foster an environment that is inviting, welcoming, create a culture with our staff, highlights sensitivity to the matters at hand, and trying really to drive home the point that we're partners with our patients on this journey that they're going through. We're not just here as a means to an end. We're here to listen, to help steward them through the process. Of course, we offer our expertise, but it's more than just a regular doctor. It's really forming a partnership for the process.
It sounds like the first thing and the first consideration is deciding and determining the goals and establishing the relationship and just making it a very compassionate kind of dialogue that's happening so that there's some understanding of to what the patient long-term is wanting out of it. So I understand that you are a reproductive endocrinologist, fertility specialist. What other practitioners are involved in the process?
So we have a staff of about 75 people here and 3 doctors. It does take a lot of different people with different areas of expertise to help patients through this process. We have our clinical assistants who serve as the physician's assistants throughout the process, whether it's sitting in the room and acting as a medical scribe, taking notes on the conversations, helping give patients instructions on which medications to take and when to return. We also have our very critical laboratory team. We have the embryology lab, the andrology lab where the sperm is processed, and the endocrine lab where the blood samples are processed. So this set of staff has an entirely different skill set and set of expertise that's critical, ensuring on a more scientific level that patients are getting the best care possible. We work with sonographers. They help perform some of the ultrasounds for patients who are going through IVF cycles. Then we have our finance team who help patients navigate through the very complex world, health insurance, what's covered, what's not covered, helping define things like deductibles and copays and co-insurances, these terms that are kind of oftentimes flung around quite casually, which may not be understood by all of our patients, especially initially. We really try to do our best to empower our patients to learn the lingo from us and really understand exactly what's going to be covered by insurance and what's not, so that there are no surprises. The last thing we want is a surprise in terms of, oh, I didn't know that I was going to be responsible for this, bill, because in that case, it's just adding additional stress to an already very stressful situation.
Sure. There are multiple types of IVF and different fertility treatments. Can you talk us through the process of determining what is best for each patient and how you go about that?
Absolutely. At that initial consultation, after we've had this conversation, in the normal course, I'll do a vaginal ultrasound to look at the uterus and the ovaries, and we'll do some routine blood work to look at hormone levels, routine infectious disease screening, routine genetic screening. And if the patient comes with a partner, for the male partner, we'll also do infectious disease and genetic screening. Then, as additional parts of the initial evaluation, sometimes include a hysterosalpingogram, or HSG. This is a radiologic study where some liquid is put into the uterus, some x-rays are taken to confirm that the liquid fills the uterus normally and then spills out of the fallopian tubes normally, indicating that the tubes, which are the conduits through which the egg pass to get to the uterus, and usually the sperm and egg meet in the tube, that's where fertilization usually takes place. We need to usually make sure the tubes are open, that HSG test. One of the drawbacks there is it's quite unpleasant. The test itself is. Not everyone will necessarily need that, but I would say 75% of patients end up getting that done early on in the process.
Okay.
And then on the male side, a semen analysis to ensure that the quantity and quality of sperm is in the normal range. And that essentially encapsulates the initial evaluation. Then usually we'll reconvene maybe 10, 14 days later, either in person or by telemedicine, if that's easier, to review the results and formulate a plan. But some patients come into us who have been unsuccessful with IVF several times already. They've done this initial testing. They're looking for another opinion or another approach in terms of what types of stimulation protocols might be optimal for them if they're trying IVF again.
Sure.
And so for those patients, the process is much more streamlined because they're often eager to just go straight into another IVF cycle and are already somewhat well-versed in the process itself. Which brings me to, how do we determine what's the right treatment option for a given patient? And that is incredibly patient dependent. We generally try to keep things more natural and less invasive if and when we can. Interventions like intrauterine insemination, or IUI, where we monitor a female partner's natural cycle with ultrasound and blood work to get a sense of when she's ovulating. Shortly before ovulation, have her take one medication to induce ovulation. And then around the time of ovulation, ovulation being the time where the egg is being released from the ovary, around the time of ovulation, we collect the male partner's ejaculated semen, or if someone's using donor sperm, use the sperm, concentrate the sperm in a very small amount of liquid, and then insert it directly into the uterus. That's the IUI process in a nutshell. Most of our patients are IVF patients. That's really our main area of expertise. We have additional areas of expertise in women who have diminished ovarian reserve or lower egg quantity. That's where we really excel. And that's where these IVF options of mild stimulation or natural cycle often come into play. If someone has gone through IVF elsewhere and hasn't had an optimal response in terms of number of eggs retrieved, or the embryo development was not as good as it was hoped to be, often be indications for a less aggressive, more mild approach to the stimulation protocol, where lower doses of medications are used instead of only high dose injections, using a combination of pills with lower dose injections to stimulate the ovaries less aggressively, retrieve a similar number of eggs, but hopefully higher quality eggs that will yield higher quality embryos and hopefully get to success in that manner.
Thank you for talking me through all of that.
Yeah, and I'll just add on, so that was mild stimulation. With natural cycle IVF,
Okay.
that is often a good option in women who have very low egg quantity, where even when the ovaries are stimulated aggressively or very gently, we only see one follicle developing. The follicle is the structure in the ovary that contains the egg.
Okay.
And all menstruating women are developing follicles naturally on their own. Usually one follicle becomes the dominant follicle. That's where ovulation takes place from. So with natural cycle IVF, we don't give any medication initially. We hone in on that follicle that becomes the dominant follicle, then maybe 2 or 3 days of low dose meds around the time of ovulation to help us maximize the likelihood that we actually get that egg, and then fertilize that egg and eventually return it to the uterus.
Because at Inspira, we see many patients who have endometriosis and talk about, infertility and are experiencing infertility. I know that I was fortunate to connect with Generation Next at the EndoFound Endometriosis Patient Symposium. So I know this is one condition that can cause infertility. What are some of the other diagnoses that you sometimes see that impact fertility?
Sure. So it's really important and often not as much spoken about that fertility takes two. And we're not talking about just female factor. There is male factor, and fertility plays a role in about 30 or 40% of couples who are having difficulty getting pregnant. The male analysis is more simple in terms of we ask some questions, we do some blood work, and we check a semen analysis. And that generally gives us the information we need to figure out, is this an issue with the male and the sperm? Is this perhaps something related to the female side? Oftentimes we do the entire female evaluation and the entire male evaluation, and we don't find anything that's out of range or abnormal. The sperm is normal, uterus looks normal, ovaries look good, hormone levels are fine, no infections, genetics are good. Okay, doctor, what's the problem? We've been trying, we've been having sex for a year, timing it around ovulation. I'm only 35. Why isn't this working? That is a pretty common scenario that we deal with, which is categorized as unexplained infertility. Frustrating, because if everything is normal, why isn't it working? We're all scratching our heads. But at the same time, a good category to be in, because the vast majority of people with unexplained infertility will go on to be successful. May take IUI, may take IVF, but we can get them there. Diminished ovarian reserve, low egg quantity, a common category that we often handle. Tubal factor is another one, where the fallopian tubes may be blocked, either without any explanation or history of a previous infection sometimes, history of an ectopic pregnancy. Instead of implanting in the uterus, can end up implanting in the fallopian tube, thereby damaging it, which can lead to blocked or otherwise compromised tubes. Those are the biggest categories of issues that we see. There are some other less frequent categories as well, but that would encompass probably 95% of the fertility patients that we see.
I know that many women in New York City and right now in the world, because of the culture, are waiting longer to start trying to have children because of careers, because of X, Y, and Z. What would you say your recommendations are for women who are planning to put off having children until after 35 in regards to egg freezing And what can you tell us about egg preservation and egg freezing in general?
Thank you for bringing that up. I wanted to bring up this topic because it's an important topic and has undergone so much recent evolution in terms of options, efficiency of egg freezing, accessibility in terms of insurance coverage and costs, and general, the number of people who are freezing their eggs is increasing year over year significantly. And the age at which women are freezing their eggs is drifting younger year over year.
Okay.
Generally speaking, fertility peaks in the 20s, begins to decline in the 30s, and that decline accelerates in the late 30s into the 40s. Nothing magical happens at 35. It's really an arbitrary age, but yes, things do begin to change in the 30s, and the decline does accelerate into the late 30s. So if someone is, the younger a woman is, the more eggs she's going to have, and the higher quality those eggs are going to be, meaning the higher the likelihood that an individual egg is actually going to become a baby at the end of the day. As women get older, the quality and quantity decrease. One way to kind of elucidate this quality issue is the likelihood of miscarriage increases as women get older. Miscarriages are usually due to chromosomal abnormalities of the embryo, either extra chromosomes or missing chromosomes, and those abnormalities almost always arise from the egg. If someone's not interested in having kids in the near term, freezing eggs or embryos is an option. So if a patient comes in, single woman, say she's 30, she knows she wants to have kids, but isn't ready right now for whatever reason, career, relationship, doesn't matter. Yes, we have the option to freeze her eggs. And briefly, that would entail the initial consultation, initial round of testing, and then eventually stimulating the ovaries with medications, removing those eggs from the ovaries and freezing them. And then we would save them. Fast forward, say 8 years, she's 38. She has a partner at that time. She tries naturally. She's not successful. Then we'd be able to use those eggs at that time. The duration of time for which eggs can be frozen doesn't seem to have an upper limit. And the freezing technology, the freezing technique has been improving over the past couple of decades, continuing to be refined in terms of laboratory protocols and achieving better and better outcomes in terms of egg freezing and IVF in general. Then there's the option of freezing embryos. If a patient has a partner and she wants to freeze embryos, that's also an option, which is not an uncommon paradigm that we are seeing more and more. Young couple comes in and they want to have kids, but not right now. Whatever, they want careers that they're focused on, or travel, or whatever the case may be. For couples, we'll often do that same process, stimulating the ovaries, removing the eggs, but then fertilizing the eggs with the sperm, making the embryos, culturing the embryos in the laboratory for about a week, biopsying the embryos, freezing the embryos, sending the biopsy samples to an affiliated laboratory for additional testing, who then reports back to us to let us know if a given embryo has normal chromosomes or not. This way, we have a lot more information about the embryos we're freezing and can better assess the likelihood that a given embryo will become a baby at the end of the day or not. And for some couples, depending on the nature of the relationship, doing a split of egg freezing and embryo freezing might be a good option, so that the female partner isn't necessarily committing all of her eggs to a single sperm source in case that relationship doesn't last.
What advice would you recommend to women who are time frame age? The younger is better. Just try to freeze younger than in your late 30s.
Yeah, so younger is better, but too young isn't necessarily the best option, because I'll take it to the extreme. If a 21-year-old comes in and says, I want to freeze my eggs, yes, we could do it, and her eggs are probably going to be as good of a quantity and quality as they ever will be, but the likelihood that she's ever going to need those eggs is relatively low, because she hasn't, had the opportunity to live and see what life will offer. I think there could be an age that's too young, and finding the balance becomes a really personal choice for patients. But if anyone is interested, highly encourage a consultation with a fertility specialist.
Okay.
Come see us. Let's meet. Let's talk. Probably let's just do some initial testing, ultrasound, blood work, check hormones,
Right.
and see. Talk about the process, because in unusual cases, young women will have very low egg reserve. Usually, egg reserve declines with age.
Mhm.
For some women, egg reserve might be low at a very young age, in which case it might be beneficial to freeze eggs very young.
Thank you for that. I know that you mentioned with the IUI that, and I think I'm saying the acronym correctly, with the IUI that there's sometimes some discomfort, but are there any risks associated with any of the procedures and testing and things that we've already discussed?
Risks, yes, there are some risks. With IUI, which is the intrauterine insemination, the risks are really minimal. It's conception is taking place in the woman's body, and there's really minimal manipulation of anything except for concentrating the sperm that we are putting into the uterus. And IUI doesn't seem to affect the likelihood of adverse pregnancy outcomes or birth defects or anything like that. Infertility in and of itself does seem to increase the risk of pregnancy complications slightly and birth defects slightly, whereas in the general population, the risk of birth defects is about 2 to 3%. This
Okay.
is something, could be something like overlapping toes, could be something like a heart defect or anywhere in between. With patients who undergo IVF, that risk does increase to about 4 to 5%. So still unlikely, but a little bit higher. But it's not clear whether it's the IVF process, which is not natural. If IVF, we're stimulating the ovaries, we're removing eggs from the body, we're fertilizing those eggs in the lab with the sperm, culturing the embryos in the laboratory incubators for about a week, usually biopsying embryos, freezing them, eventually thawing them. There's a lot happening that's not natural. Certainly conceivable that there would be this increased risk of birth defects, but also a slight increased risk of pregnancy-related complications.
I see.
What am I talking about? C-section, high blood pressure during pregnancy, diabetes during pregnancy, abnormal placental development, heavy bleeding at delivery. Basically, across the board, the likelihood of obstetrical or pregnancy-related complications is a little higher.
Okay. So I know that you have published a lot in many scientific journals, and you are most aware of the research. Where do you see fertility treatments advancing in the next 5 years?
I think the main area where we continue to see improvements are in methods of embryo selection. With IVF, how do we know which embryo is the embryo that's most likely to become a baby? Right now, there are a few different categories of selection that are being employed. One is, which has been around a long time, is looking at the embryo under the microscope, assigning a grade to it, and the better the grade, the better it looks, the more likely it's going to become a baby.
Mm-hmm.
That has proven to be helpful, but imperfect.
Okay.
Certainly. Now, the newest standard, which is not that new, but is routinely done at most IVF centers, is PGTA, pre-implantation genetic testing for aneuploidy, where this is the process by which an embryo is biopsied. About 5 cells are removed. The embryo is then frozen. Those 5 cells are analyzed to see if the embryo has normal chromosomes or not. Helpful information to have before determining which embryo to put into the uterus, but it has some disadvantages. Most notably, it's an invasive procedure. We're removing 5 cells of an embryo that has about 100 cells, and it's not totally clear if that could potentially damage an embryo that otherwise would do perfectly fine. Non-invasive methods of embryo selection are being studied, where liquid around the embryo that's taken from the culture dishes, which are the dishes that the embryos are bathing in as they're in these incubators for about a week, analyzing that fluid can shed light on the chromosomal status of a given embryo, but there are lots of limitations to that technology so far. And then the other big category that I think we're going to continue to see advances is artificial intelligence in terms of embryo selection. Mm-hmm. So how can, and more specifically, AI from an imaging standpoint help determine which embryos are going to be most likely to become babies versus not. It's been studied for more than a decade now, but nothing has come to the forefront yet that has clearly demonstrated that it can really predict live birth versus not, which is the metric that we're looking for, like which embryo will become a baby at the end of the day.
Got it. Well, that's exciting to see if that comes and they have the final word from the decades worth of research and studying. Do you have any final words of advice to the listeners?
I think that challenges with fertility can present an incredible amount of stress on a relationship or on a single woman. I think it's really important to choose the right doctor and the right practice. There are a lot of options in this town, which is wonderful in New York. I don't know if all your listeners are in New York, but the amount of expertise available is remarkable. There's so many smart people doing this, but finding someone who's not only bright, but the right personality fit, I think is really important. If you have questions, if you have concerns, going for a consultation is a really valuable step. You're not committed to doing anything at that point. You're just starting with a conversation, maybe doing some initial testing to learn more, but not signing up for treatment necessarily. And I think that the piece of advice where I would say, if you have questions about freezing your eggs or questions about, we've been trying for even a few months and it's not working, should we be doing anything differently or should we be doing some testing so we're not wasting time? I think that would be the advice that I would want to impart on the listeners.
Amazing. Thank you so much, Dr. Nejat. This has been an amazing conversation. And I know I can speak for all of the listeners that this truly is a gift, this conversation, so that we can really learn from an expert like yourself and not feel like we're out there not knowing where to find out the information. So thank you. And I want to thank all the listeners. If you are wanting to find out more information and wanting to connect with Generation Next Fertility, we are including their profile and the information in the description of this podcast and also on our Instagram. And so thank you, and tune in next time for another informative conversation on the Know and Do Better podcast.
Dr. Carbonati, thank you so much for having me. It was a pleasure. And listeners, thanks for tuning in.